So in this presentation, I'll just be going through initial approach, evaluating the patient, history and examination, treatment, and so on. And persons might have remembered this slide from Dr. Figueroa's time, when this is just when they had launched the Know Your Status campaign. The then Minister of Health, John Jr. at the time, was on the poster, "We want you." And really, it's okay, go ahead talking. It's just to reiterate what PLHIV is saying. We really want to have people know what status they are, because there are many persons not knowing their status, and there are many persons who not know their status and need care. And and if we can get persons in earlier, then it would be better off for us. So basically, any patient that comes to your clinic, your office, somehow, some way, you get into that mode of opt-out testing. And with the patient, it's like with any other disease, really. You want to listen to his or her concerns, and it's going to be very important not to be judgmental, or else they'll just close up and you only hear what they think you want to hear. And that is actually also a process, because over time with your relationship with the patient, you will guarantee that you're going to get many surprises, as to what they finally disclose to you and so on. You want to go through with them what they know about the HIV and explain things simply and addressing their fears. And you want to emphasize that HIV really, it's manageable. Just like diabetes, nobody really wants diabetes, but you can manage diabetes and you can control it. Similarly with HIV. And that you want them to really know and urge them to seek care help when they need it. Because that is also, that initial moment seeing a patient is also a very, very fragile time. They tend sometimes, that's where we have some of the big fall in the cracks, I would call them, where they've got their tests, they have maybe gone on one visit to the practitioner, after that they've disappeared. Their own fears, whatever, have come, and then they come late to the hospital maybe. So these usual healthy lifestyle advice, which you are all very apt about, is applicable to our persons living with HIV. And we want to make some assessment at the initial state of their psychological state. Not any big fancy thing, just to get, we want to really know what state they are in, because that is going to determine how long you're going to spend that session with, and the first set of initial sessions to get through to them, okay? If they're really, really distraught, don't try to tell them too much. They won't remember it anyway. And over time, you want to see what's their acceptance of their diagnosis and so on. As you know, with chronic disease, terminal illnesses, people go through these different stages of denial, acceptance, and so on. And you would go through history and examination, you do your lab investigations, and so on. And we will, as part of our initial assessment too, we would want partner notification. So another member of the team is Mr. Jeffrey, is some prophecy, Jeffrey. Another Jeffrey Robinson, you could just stand. He's our contact investigator at Comprehensive Health Center, so he's going to talk a little bit about partner notification. So some baseline investigations, and the national program is coming up with the treatment guidelines, which will include all of these recommendations. So these might be a little bit off, but when you get the guidelines, you'll follow those. I'm not sure, I didn't get the time to check with the draft. So, but must weigh the patient, basic, simple things. Confirm their HIV test, because many persons are doing some rapid tests under some not ideal standards. And so we really need to make sure that we confirm the test. You weigh your patient and so on. Those are simple tests, complete blood count, a syphilis test. HIV is a sexually transmitted infection. You want to make sure that they don't have syphilis as well, and so on. Urinalysis, pap smears, and so on. And sometimes it would be nice if we could do the renal functions and liver function tests and so on. And as indicated, pregnancy tests, etc. This is just a little schema to show the pathogenesis of HIV. So many persons will come to us most in the stage with related symptoms, or we may get some who are in latent. Latent is in quotations, because more and more they're realizing it's not really quiet. Things are happening, but it's certainly subclinical. And if we can get more and more persons to know their status, and if we are more and more trying to get people to assess their risk, then we may be getting more people in the early stages of seroconversion. And this is just a list of some of the AIDS-defining conditions. And this is just going through the natural history. So persons at infection will have a normal CD4, and over time that CD4 will decrease. Their own immune system will try to, do some killing of the viruses and so on, and the CD4 will make some recovery, but over time it will gradually deteriorate. And similarly, that is matched with the constitutional symptoms. The viral load will be very high in the early stages, and it will again decline naturally, and then over time it will increase if there's no treatment. And this is just a schema. So I borrowed actually this from the iTech series of slides, and just to show that there are patients who are at different progression levels. So this is a sort of typical progression where the CD4 will go down, the viral load will come up, and then things will sort of plateau, and then gradually go down. And this is the long-term non-progressor. This person, they will get infected, but their CD4 remains at a. I've been hard time to too many buttons for me. This one is the point. Yes. Thank you. So the CD4 will remain pretty, high, nearly over time, and their viral load will remain pretty low, even though they have HIV. So these are the persons that will be looking fine 20, 25 years, indefinitely maybe. Some things that we don't fully understand with everyone. And these will be the rapid progressors. So as Clive had said, sometimes in the persons will within a year, but in some cases within a couple months, persons will rapidly progress. We have had persons who was negative and in a year, and then the next year tested positive, and in no time they have AIDS. So you do have your rapid progression. So it's important to realize that not everybody is progressing their HIV at the same rate. And then this is just one of the characteristics that you might see. It's pretty common, the papillopyretic eruption. Don't rushing off to refer to the dermatologist. Yes, you can, but this is a common presentation. And of course, we would want to give our prophylaxis for patients who are with clinical AIDS. We give cotrimoxazole, a double-strength tablet, once daily. We may decide to give fluconazole or acyclovir for herpes, and for CD4 below 50, we would give the azithromycin. I wanted to bring up this because there are some unexpected presentations, so to speak. Many of us have got surprises. We never expected our 65-year-old housewife from Norbrook to have HIV. And we were investigating this person for pneumonia and all of this in hospital, and so I've had colleagues who have told me of some of these surprises. I certainly have had that surprise. Many persons are discovering it on taking out their insurance. Persistent sinusitis is another one that I have found to be really eye-opener. And many times, to even persons who are known to be HIV positive, they're in a very good immune status. CD4 is pretty high, but they have sinusitis chronic. We had a patient in private practice with that. Chronic sinusitis all the time. Her CD4 is like 800, but nothing would help that sinusitis, and we decided to put her on ARVs for other reasons too. And the sinusitis, I didn't recognize her because she now did not have a nasal voice anymore, which was like her norm. So, it can be a sign to watch. It's hard to say now because with all of this Riverton smoke and so on, so we'll be having quite a bit of that. And the mental illness, it has varied presentation, so just always remember that too. Shingles, of course, people know about that, even a younger person with shingles, even though life is really very stressful, and that alone will cause you to have shingles. But there's other things. Elderly, What about this never sexually active? And I really mean never sexually active. Not, no, I'm not having sex, and you know they are, but these persons who are not sexually active, young persons with HIV. What's that? Hmm? Mother to child transmission. Because we do have mothers who are had a baby 25 years ago, maybe even, or 20 years ago, who had a child. The mother might be a long-term non-progressor. She doesn't really have any signs and symptoms. Nobody thought of testing back in those days. And then, so there may be few cases, and Dr. Dunkley Thompson had done a paper on this, the hidden population in the West Indian Medical Journal. Yes, yes, we have learned along the line. You have to phrase these questions: sexually active, having sex, even when you say partners, because persons will be having sex with other persons, but they don't consider them a partner. So you have to be careful when you're asking about having sex. Who are your sexual partners? So for antiretroviral, we would start if person has AIDS and they are able. If the CD4 is less than or equal to 350, less than 350 cells. If a pregnant woman, as Clive had said, regardless of the CD4, we will give consideration to persons within the 350, 500 if there are other things in the history that we need to consider. Persons with HIV-associated nephropathy should be on medication. Persons with hepatitis B and HIV and hepatitis B is in need of treatment, or in general, we might decide that they should also be put on antiretrovirals. And we would consider, in US and some of the other first world countries, this is a criteria for treatment, persons who are elderly. And the idea is thinking their immune system is already on the decline, so we don't want it to decline any further. But patients may actually wish to delay their medication. So it's not a edict from the doctor, it's a discussion with the patient. And this is just showing you the risk. So the higher the CD4 and the lower the CD4 and the higher the viral load, the more likely that person is going to have progression to AIDS quicker. Okay, so in other words, we really need to put persons on treatment at the lesser CD4. Remember, this cutoff used to be 200, so no longer are we using the 200 cutoff. It's 350 at the moment in Jamaica. And this is just showing you the life cycle at the different the different points that you can have medications, that the entry inhibitors or the reverse transcriptase inhibitors or the integrase inhibitors. And Clive showed you some. These are those that are available in Jamaica. I know sometimes it can be very, like, how do you remember all of these tongue twisters names? But over time, you will get used to it, I promise. And the ones that are in the sort of gray, Sabidine, they're trying to take out. The World Health Organization has really said it causes too much side effects, the peripheral neuropathy, etc. So we're trying to phase that one out, but we still have a couple persons on it. I know I had a patient who refused to come off of it. She said, this thing works. But when I pointed out, she came and saying how her face is getting thin and she's getting skinny. And I was trying to explain to her that was a dystrophy. But when she believed